when I don't have my monitor set up right. All right, bleeding. So this is the standard. Just like any other chapter for trauma, we're going to apply the fundamental knowledge to provide basic emergency care and transportation based on those findings, okay? So bleeding, what are we going to do? We're going to recognize it and we're going to manage it. We're going to talk about the pathophysiology, how we assess, and the management of that bleeding. All right. Introduction, important to be able to recognize bleeding, understand how bleeding affects the body. Bleeding can be both internal and external. Bleeding can cause weakness, shock, and as we know, you run out of blood, you die. So we're going to review some anatomy and physiology. Again, like I said, every time we start out with reviewing the anatomy of the subject we're starting with. The cardiovascular system circulates blood to cells and tissues. It's going to bring that oxygen and nutrients. It carries away waste products. And that's really what's responsible for supplying and maintaining adequate blood flow. Hopefully that is not new information to anybody. All right, 3 parts. We have the heart, or the pump, the container, which are the blood vessels, and the fluid, the blood and body fluids. Let's see what just happened. I apologize, guy. PowerPoint is not happy with me. Stand by. Real quick, guys, what chapter is this? 25?
Yes.
26.
No, 26. Yes. Sorry.
26.
All right.
Chapter 26.
Let me re-pull it up here. Let's see. Here. Okay. Switch this back. Sorry, guys. All right, so again, we have a diagram. This shows a very basic diagram of the cardiovascular system. Everyone should have seen this before, right?
Yep. Yes.
The heart needs a rich and well-distributed blood supply. Works as 2 paired pumps. You got the upper chamber and the lower chamber, the atrium and the ventricle. Blood leaves each chamber through a one-way valve. And again, here's a diagram of the heart. Anybody want to take a stab at telling me how blood flows through the heart?
I don't know the valve names, but I know like the right atrium, the blood comes in, and it goes down through a valve into the right ventricle. Then that deoxygenated blood goes into the lungs through the pulmonary aorta. And then I'll let somebody else take it.
It goes through the pulmonary artery into the
Perfect.
lungs and becomes oxygenated, and it comes back through the pulmonary vein into the right atrium, goes down into the left ventricle, and it's pumped into the aorta. And oh geez, is it
Out of the body.
the inferior vena cava goes to the lower portion,
Look at
and
you.
and the superior vena cava goes to the head and the upper extremities.
Perfect. Look at you. You got it. You got it. Good job.
I forgot to
thing.
talk about though that we didn't do the oxygen and CO2 exchange, but
You're
through the
perfect.
capillaries.
All right, you guys got a good grasp on that. Just remember the heart, the pulmonary artery is the only artery in the body that takes non-oxygenated blood, and the vein, the pulmonary vein, is the only one that actually transports oxygenated blood. So super important to remember that. That's kind of a key thing. To help you remember those valves, you have the tricuspid and the bicuspid. The way I remember it is you got to try something before you buy it. So you're going to go get a car, you try it before you buy it. Tricuspid on the, if you're looking at the heart, and then the bicuspid. Good enough? Cool. All right, we'll move on. And again, we just talked about some of this. Arteries carry the blood away from the heart. Smaller arterioles carry smaller vessels, and the capillaries are where those the cells exchange those waste products and oxygen. Sorry, guys, I'm on call tonight, so just checking my phone. Venules are very small, thin-walled vessels that empty into the veins. Veins are the ones that carry the blood from the tissues to the heart. Oxygen and nutrient pass from the capillaries into the cells. Waste and carbon dioxide diffuse from those cells into capillaries. Any confusion on that? Good deal. See a lot of head shaking. All right. Blood contains red blood cells. That's the responsible party for transportation of oxygen to the cells and carbon dioxide away from the cells to the lungs. And here's a cool little picture of those red blood cells. And they actually look like little donuts. That's an accurate depiction of, that is 100% what they actually look like. White blood cells are responsible for fighting infection. Platelets are responsible for forming clots. And plasma is some of that other liquid that's mixed in with the blood, okay? The way blood clots form depends on blood stasis, changes in the blood vessel walls, and blood's ability to clot. When tissues are injured, platelets begin to clot at the injury site, aka a scab, okay? Red blood cells become sticky and clump together. We're going to monitor the body's needs, adjust blood flow, the autonomic nervous system monitors the body's needs, adjust blood flow, automatically redirects blood away from other organs to the heart, brain, and lungs, and kidneys in emergency. That's called shunting. So the body's going to shunt that blood to the most essential thing, which is its brain, okay? And it's going to adapt to maintain homeostasis and perfusion. So homeostasis is the body's normal. So it's going to try to always get the body to a normal state. Perfusion is the circulation of blood within an organ or tissue to meet the cell's needs for oxygen, nutrients, and waste removal. So we need to perfuse our body to get all the nutrients we need, but also to remove that waste. Speed of the blood flow. Fast enough to maintain circulation, but slow enough to allow the cells to exchange oxygen and nutrients. And it's very important to be in that kind of middle section, okay? Some tissues need a constant supply of blood, while others can survive with very little. All organs and organ systems depend on adequate perfusion to function properly. Death of an organ system can quickly lead to death of the patient. We know this. If someone's kidneys shut down, someone's heart shuts down, someone's liver shut down, it usually results in death unless something is done medically to prevent that from happening. Emergency care supports adequate perfusion until the patient arrives at the hospital. The heart requires a constant supply of blood. If the heart runs out of blood, it's game over. There's nothing else we can do. External bleeding. Anyone want to take a guess on what external bleeding is?
What we
Jason,
can visually see.
Yeah, good job. So it's bleeding visible outside of the body. Pretty simple. What we got to be worried about is serious external bleeding. It may be difficult to tell the amount of blood loss. Blood looks different on different surfaces. So if you have a liter of blood in carpet versus a liter of blood on hardwood floor, it's going to look a lot different. The body will not tolerate a blood loss greater than 20% of the volume. Changes in vital signs with significant blood loss will occur. I would know this right here. This is a test question. These are signs of significant blood loss. So take a second, read over those. So increase in heart rate, increase in respiratory rate, and a decrease in blood pressure. Now, if you think about that, it makes sense, right? So if we lose blood, our heart's going to work faster to move the blood that we have left. Our respiratory is going to increase because our body's now getting in this shocky state, and we're going to have a decrease in blood pressure because, well, we have less fluid in that tank. How well people compensate or make up for that blood loss is relative to how rapidly they bleed. An adult can comfortably donate 1 unit, 500 mL of blood, over 15 to 20 minutes. If a similar blood loss occurs in a much shorter time, the person may rapidly develop symptoms of hypervolemic shock. Consider age and pre-existing health. I'm one of those people, I love to try to donate blood, but I always pass out because my body can't handle, even in that extended time frame, giving blood at a rapid rate. Here are some conditions, serious conditions with bleeding. A significant mode of injury. Patient has a poor general appearance and is calm. Signs and symptoms of shock, significant blood loss, rapid blood loss, uncontrolled bleeding. Again, these are all characteristics of what could cause external bleeding or what you may see. Arterial bleeding. Pressure causes blood to spurt and make bleeding difficult to control, typically bright red and spurts in time with the pulse. So if you ever notice that they're bleeding and it's squirting out and it seems to match their heart rate, there's a good chance that that is an atrial bleeding spot. Venous bleeding, however, tends to be dark red. It kind of slows slowly, but it can be rapid depending on the size of the vein. It does not spurt, and usually with some direct pressure and some bandaging, it'll slow down pretty quick. Capillary bleeding, that's bleeding from damaged capillary vessels. That's like a paper cut, a normal paper cut. I have seen those videos on YouTube that are crazy, but a normal paper cut. These are going to be dark red and ooze steadily but slowly. And again, here's some pictures. And you can see like B is venous bleeding, and then C is that just spurting and kind of uncontrolled. So clotting. Bleeding tends to stop rather quickly within about 10 minutes. When skin is broken, blood flows rapidly. We know this. The cut end of the vessel begins to narrow and shrink down, which reduces the amount of bleeding. Then a clot forms. Bleeding will not stop if a clot does not form. All right, everybody get that? It will not stop unless a clot can form. So hemophilia is when a patient lacks that blood clotting factor. Bleeding may occur spontaneously. All injuries, no matter how small or trivial, are potentially serious. Patients should be transported immediately. There's a few medical conditions out there where these people don't stop bleeding. And these people normally, unless they're very young, are aware of this, and they will be able to tell you that. Is Kevin on? I believe one of those is called Series K2. Just random facts, but it's one of those things that bleeding doesn't stop easily. Internal bleeding. Anyone want to take a stab on what internal bleeding is?
Bleeding internally where you can't see it.
Perfect. So yes and no. So it's inside, but there are times that you can see internal bleeding, but it's not going to be because of a wound on the exterior. It's a wound on the inside of the body. You're leaking out of some type of orifice. Injury or damage to internal organs, commonly resulting in extensive internal blood loss, can cause hypovolemic shock. Possible conditions are stomach ulcers, lacerated livers, sorry guys, my tongue's twisted here, ruptured spleen or broken bones. High energy MOIs should increase your index of suspicion for serious injuries. Internal bleeding is possible wherever the MOIs suggest the severe forces applied to the body. So heavy blunt traumas or penetrating traumas. One of the key places, which I'm sure it'll touch here in a minute, is the pelvis. Anyone want to take a guess on how much blood you can lose in your pelvis? All of it. That's the answer. All of it. You can lose all of your blood in your pelvis and in your abdominal cavity, and there's a chance that we would never see it on the outside unless you're really looking for those signs and symptoms, okay? Signs of injuries. This is something that you're going to need to know for your trauma assessments. I don't know if you all have reviewed this yet, but I would highly recommend studying this, writing it down, and remembering this. And this is something that I still use today on every single patient. All right, so it's DCAP BTLS. Deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. When you do a trauma assessment and you're going down the body, you're going to be checking for all of these things. Any questions on that? I would highly, highly recommend, guys, especially for any type of trauma test or skill assessment, that you know this. Internal bleeding is not always caused by trauma. Non-traumatic causes include ulcers, bleeding from the colon. Big one here is ectopic pregnancies and aneurysms. Common signs are pain, obviously. Swelling in the area of the bleeding. Distension. Anybody know what distension is?
Air in the stomach.
Yep, not always air. It could be blood. So just the stomach getting larger. So if I notice a patient has an abnormally large belly, I straight up ask them, hey, is your belly always this big or did this just start? You also can feel it. If it feels hard and not soft, I always joke and call it the grandpa test. You know, most people, at least in the South, grandpa's got a little bit of a beer belly, but you poke on that, it's going to be kind of soft and squishy, like a good pillow. If it seems hard and rigid, there's a good chance that something else is going on. Shortness of breath or dyspnea, tachycardia, and hypotension. Hematomas and bruising are also in this. All right, again, internal bleeding, bleeding from any body opening. So the rectum, things like that. If you were to see that, that's a sign that they might have some internal bleeding. Anyone want to take a guess of what melena is?
Black, tarry, smelly stool.
Yep, it's poop. It's really dark poop, and when you see it, you know it doesn't look right. So black and really sticky. It looks like almost like black molasses. And when you see it, you'll know. Pain, tenderness, bruising, guarding, or swelling. Again, that you usually see that wherever the affected blood is pooling. So usually in the stomach. Broken ribs, bruises over the lower part of the chest, and again, that rigid, distended abdomen. You're going to see hypoperfusion, change in mental status, weakness, faintness, or dizziness when standing, changes in skin color or pallor. And again, some of this is from that shunting we were talking about. The body is shunting it, but it also could be that they are low on volume. They don't have that blood in the tank. So when we stand them up, they're going to get weak and fatigued because they don't have that blood to supply the whole body, and gravity is working against you. Some late signs of hypoperfusion is tachycardia, weakness, faintness, and dizziness at rest. So late signs are if they're laying down and feeling weak and faint, it's probably not good because we've gotten to the point where even when the body's laying flat, the pump and the blood is not enough to keep the body perfused. And then thirst, nausea, vomiting, cold, moist skin. And the later signs of hyperperfusion, shallow and rapid breathing, dull eyes, slightly dilated pupils, capillary refills that are more than 2 seconds in infants and children, and a weak, thready pulse. Again, decreasing blood pressure and altered level of consciousness. Now, we talked the other day about assessments, about people with dark skin complexion. Does anybody remember some keys where I told you to look for perfusion? Good job, Tina. Jason, inside the mouth, under the eyelids. Again, good place to check to see if that perfusion's there.
Hey, Zach, I had a question about
Yeah.
hematoma versus a bruise. I thought they
You know-
sound like the same thing, right? I mean, what's the difference between them?
You know, I would lie to you and say to you that I have a good answer for that. I always wrap hematomas and bruises in the same category. I don't know if Morgan or Kevin have a separate answer, but hematoma and bruise I've used interchangeably my whole career, and maybe I'm learning something tonight. But I will take note and see if I can find a different answer for that. But again, I assume a hematoma is a bruise. A
But
large
you can have a bruise without a hematoma. Because isn't the hematoma the collection of blood that's underneath the skin that causes the bruise?
You know, you might be onto something.
I'll Google
Again.
it. I'm trying to Google it right now.
Bruises result from an injury to smaller blood vessels, while hematomas result from larger blood vessels. So I guess it's a big bruise versus a small
Big
bruise,
bruise.
okay?
All right.
For me, they got a bruise. I can see it. Unless it's something small, like, you know, the size of a quarter, I'm probably going to say it's a hematoma. All right, so we've talked about this over and over again. We're beating this into your all's heads about scene safety. So we need to be alert of potential hazards, especially in those violent incidents. You want to make sure the police are on scene and follow your standard precautions. Now, when someone has a massive arterial bleed, what are some precautions? What are some BSI that we're going to want to use?
Goggles.
Glasses or goggles,
Gloves, obviously.
gloves, yeah, gloves all the time.
Gown,
Maybe a gown,
mask,
yeah.
Mask.
And
face shield.
again, it just depends on preference, but the idea is to keep you safe, to keep that nasty off of you, okay? We're going to try to figure out the mechanism or the nature of that illness. Consider the need for spinal immobilization if it's trauma related, and if you're going to need additional resources. And also consider environmental factors such as weather. Why would weather be important with someone with who's got a massive blood loss? What is something we're worried about?
Well, you can't
Hypothermia?
buy someone if-
Hypothermia, because starts with an S. SH.
Oh, the
SHO.
shunting. The shunting.
Shock. We're
Oh,
worried about
shock.
shock. So we want to keep them warm. And people can get hypothermic even in temperatures as high as 70 degrees, especially if they have blood loss. Okay. So just because it seems comfortable outside, that doesn't mean your patient can't get hypothermic. So let's talk about the primary assessment. Don't be distracted by from identifying those life threats. So let's say someone's got a leg and they got bones sticking out, right? We call that a distracting injury. It looks bad, it looks painful, but let's say they also have a bad airway. We don't want that leg injury to take away from our normal assessment of things that would kill the patient the quickest, okay? Note important indicators of the patient's condition. Be aware of obvious signs of injuries and determine the gender and age of the patient. Those are all pretty common things that we'll pick up on individually. Perform your rapid exam. We're going to look for life threats and treat them as you find them. If the patient has obvious life-threatening external bleeding, address it first. Assess skin color and determine the level of consciousness. So you all have your ABCs, right? I'm going to add two things. It's not going to be on a test, but this is some more building blocks. I'm going to add D and E. Distracting injuries for D, and E is going to be exsanguination or massive blood loss, okay? So add those to your checkoffs. If you were to see someone with massive blood loss, you want to find out what's causing that very, very quickly. And I know C for circulatory, but again, it just drives home the fact that E, exsanguination, you want to make sure you're looking for that blood loss. Airway and breathing. Consider the need for spinal stabilization. Ensure the patient airway. Look for adequate breathing. Check for breath sounds. You're going to provide high flow oxygen or assist ventilations with a bag valve mask or a non-rebreather. Insert an OPA if they don't have a gag reflex and they're unconscious. All right, for circulation, you're going to assess those pulse rates and quality. You're going to determine skin condition, color, temperature. You're going to check capillary refill time. You're going to control that external bleeding and treat for shock. Have you all, on any of your skills stuff, have you all gone over the trauma assessment yet? Good. Okay, so all this should be pretty much a review for you guys. You're going to make your transport decision. You're going to assessment of the X ABCs, life threats, and determine the transport priority. Signs that imply rapid transport, tachycardia, or rapid breathing, tachypnea, low blood pressure, weak pulse, and clammy skin. You're going to investigate the chief complaint. You're going to look for signs and symptoms of other injuries, note obvious signs of internal bleeding, and assess the entire patient. All right, guys, review. Tell me, what are some signs of internal bleeding? What are some things that we could see?
bruising.
Or hematoma.
Hematomas, yeah.
You could have a rigid abdomen.
Distension.
Jennifer, really hard to hear, but I think you got it. Tina, you're right. Distension. Good job. Okay. You're gonna get that sample history.
Oh, bleeding from orifices.
Yep. Sample history. This is a key one here. Ask the patient about blood thinning medications, okay? Some common ones, Xarelto, Plavix, aspirin. There's a few different ones out there. You'll learn them throughout your career. Just make note, learn your medications, because it's important if they're on that. That can be life or death if they're on some of these high-powered anticoagulants or blood thinners. If the patient is unresponsive, you want to obtain history from medical alert tags or bystanders. You're going to look for signs and symptoms of shock and try to determine the amount of blood loss. I will tell you guys, trying to figure out blood loss is very difficult. especially if you're on scene with a patient that's been moving or they're on carpet or on floor. It's really hard to gauge that. So don't get too wrapped up trying to say, well, they've lost 502 mLs of blood. If they've lost a lot, it's not good. If they lost a little, it probably could still not be good. So just assess your patient. Sorry, guys, my 2-year-old is having a meltdown. Assess all areas for DCAP, BTLS. Attach appropriate monitoring devices. With a critically injured patient or a short transport time, there may not be time to conduct a secondary assessment. So this is when it's really important, that primary assessment, that you do a good job, because you might only get one chance to look them over. And you don't want to roll into an ER and miss something huge. Been there, done that. Get your patients naked, expose them, take a look and look over their whole entire body front to back, okay? Any questions on that? And then we're going to reassess. We're going to reassess the patient in areas that showed abnormal findings. Signs and symptoms of internal bleeding are often slow to present. Reassess an unstable patient every 5 minutes, stable patient every 15. I know you guys have had that drilled into you because I've read it about 20,000 times in the last 3 lessons that I've taught. So if they're unstable every 5, stable every 15. And again, those interventions, high flow oxygen, we're going to control bleeding, we're going to provide treatment for shock and transport rapidly. These are one of those times, again, guys, that we don't stay on scene. If they're bleeding bad and they're starting to show those signs, we need to get them moving quickly. We're going to communicate and document. We're going to recognize, estimate, and report the amount of blood loss and how rapidly and over what period of time it occurred. Communicate all relevant information to the staff at the receiving hospital. And then you're going to document all those injuries, what you did, and the patient's response. Every time I take a trauma to a hospital, I like to tell them when I got there, if that bleeding wasn't controlled, I was able to slow it down. Or if they're still bleeding under those bandages, hey, I've applied pressure for the last 20 minutes and this thing is still bleeding pretty good. You want to make sure you're very open in that communication. We talked about this already. Follow your standard precautions, wear your appropriate PPE. You're going to make sure they have an open airway and breathing is adequate. You're going to provide high flow oxygen if needed, and control obvious life-threatening bleeding. Several methods are available to control external bleeding. Direct even pressure and elevation. So you want to get it above the heart, you want to push hard, and you want to push continuously, okay? You can use pressure dressings or splints. You can use tourniquets, hemostatic dressings, and wound packing. Any questions on those? We're going to touch base on those as we continue, but all right, direct pressure. This is the most common and effective way to control external bleeding. Pressure stops the flow of blood and permits normal coagulation to occur. You're going to apply direct pressure with your gloved fingertip and hand over the top of a sterile dressing. You want to hold uninterrupted pressure for at least 5 minutes. I'm going to hold it for a long time because I don't want it to start bleeding and have to start all over again. Now, if your hands are full and you're trying to do a bunch of things, you can pull in a random rescue person, a firefighter, or even if the patient is alert and oriented enough, hey, I need you to hold pressure on this and don't let go until I tell you. So don't be afraid to pass that torch off to someone else if they're bleeding in multiple spots, and you've got to take care of that. You're going to firmly wrap a sterile, for pressure dressings, you're going to firmly wrap a sterile self-adhering roller bandage around the entire wound. You want to stretch the band tight enough to control the bleeding. Do not remove any dressings until a physician has evaluated the patient. A tourniquet is useful if the bleeding cannot be managed with direct pressure. So you got a pressure dressing. You're going to stick it on, let's say it's right here on the forearm. They continue to bleed through it. What would you do if they continue to bleed through that dressing?
Another one.
You're going to put another one right on top of it. I've had them where they're sticking out like a third arm. Okay? You're just going to keep bandaging and wrapping and putting pressure. Now, if you get to the point where you still can't control it, that's when we move to a tourniquet, okay? All right, hemostatic agents. I don't know if you guys carry it up here. This stuff is expensive, and a lot of ambulance services just don't carry it, but it's good to know about. Gauze can be packed into larger wounds with direct pressure is inadequate or application of a tourniquet is not possible. A hemostatic dressing is impregnated with a chemical compound that slows or stops the bleeding by promoting clot formation. So basically this stuff has like a clotting agent that when you put it on the wound, it kind of gels it up. Now in the past, some of the older stuff, it actually used to burn the patient. It would help cauterize the skin by chemical burns. Some of the newer stuff doesn't do that anymore. So if you have it, it's it's a good thing to have, but a lot of places don't carry it. Tourniquets, useful if a patient has substantial bleeding from an extremity injury. Several types of commercial tourniquets are available. Junctional tourniquets allow for compression of life-threatening bleeding in areas where standard tourniquets are not possible. If you all ever get into a spot with your EMS services and they don't have junctional tourniquets, I highly, highly, highly advocate for them. These can be life-saving. The military has really done a lot of science behind these, and they've saved a lot of lives. It may be indicated for severe hemorrhage at the junctions of the torso or the arms and legs. So shoulders, right there in the like on the legs, right near the groin. Does anyone know what a junctional tourniquet looks like? I don't know if there's any pictures in here or not.
It looked like a big strap, and then it had this thing that you twist down.
Yeah, so
puts
it
pressure
looks like
on
a big old
arteries.
plunger. A
Yeah.
plunger, right? And you strap it over almost like a belt, and you crank this plunger down. And what it's doing is it's putting pressure on those big vessels at those joint sites. Super cool tool and super easy. Now they also make some that work almost like a blood pressure cuff. You put it over it and you pump it up, and it has a blood pressure cuff with a big hard plastic disc in it. And as you pump it up, it also presses on those vessels. So it just depends on a few different types, but they work really well. Splints, air splints, soft splints or pressure splints can control internal or external bleeding associated with severe injuries. Immobilize fractures, act like pressure icings. I'm sorry, guys. For some reason, my PowerPoint keeps crashing. Bear with me. Why don't we take a couple minute break while I get this pulled back up?
I'm a YouTube junkie, and when I see something, I go and YouTube it, and I just gotta find it on YouTube, and sometimes it's pretty cool stuff. You get down that rabbit hole though when you get on YouTube. Yeah, pretty bad.
My husband will like start out watching a fire video and end up watching something to do with a zebra.
So weird how yeah.
All right, guys. Is everyone still here, or you all still need a break? Sorry,
No.
I don't know what's going on with PowerPoint today.
I think we're here.
All right, cool. Sorry. I've never used an air splint for bleeding control. I will say vacuum splints are really cool if you get a chance to use them, but I've never had the opportunity to use it for bleeding.
So you would put the dressing on and then put that air splint over it and pump it up? Is that
Yeah,
basically
so
what they're
some
saying?
of them are some of them are work by inflating and putting pressure in. And then for me, I had vacuum splints. So you would wrap it around, and then these splints were made with like almost like beanbag material on the inside. So when you sucked all the air out, they would turn super rigid. So there's a few different types of splints and stuff out there. All right, pelvic binders, a type of splint that may be indicated for suspected closed, unstable pelvis fracture. Helps to control internal bleeding. Again, another tool that if your service doesn't have them, they're fantastic. The days of wrapping pelvises in sheets is no longer really acceptable. Pelvic binders are the way to go, and they're not too expensive. All right, bleeding from the nose, ears, and mouth. Several conditions can cause this: skull fractures, facial injuries, sinus infections, abuse of nose drops, and dried and cracked nasal mucus. I also will add cocaine use into this as well. High blood pressures, blood clotting disorders, trauma, and cancer. Epistaxis or nosebleed is a common emergency, especially on those that have blood thinners. Occasionally, it can cause enough blood loss to send a patient into shock. Yes, a nosebleed can kill someone, or at least get them close to it. Can usually be controlled by pinching the nostrils together. Bleeding from the nose and ears following a head injury may indicate a skull fracture, may be difficult to control. Do not attempt to stop the blood flow. Loosely cover the bleeding site with gauze pads and apply light compression with a dressing. All right, a target or halo-shaped stain may occur on the dressing if blood or drainage contains cerebral spinal fluid. So in theory, if you were to take a gauze and they're bleeding out of their ears or their sinuses, and you were to take a blood sample on a piece of just gauze, you would see this yellowish haze around that blood. I can tell you, in all of my years, I've never actually seen that work, ever. But they say that works.
Thank you for your honesty.
Yeah, Kevin and Morgan might have a different experience, but I've never actually seen that work.
It must look different though, the blood coming out of the ears with that fluid in it, right? I mean, do you see a difference a little bit?
No, because I think it's kind of like a funny way I'm thinking of explaining this. You ever get jelly and the jelly has like the clear fluid around it? So you got jelly, which is thick and firm, and then you got that watery stuff. You really wouldn't notice it unless you touched it or got it onto something. And then you notice that there's kind of that liquid mixed in with the jelly. That's kind of what, blood is thick. That fluid's kind of thin and runny. Go ahead, Morgan.
That's a really gross analogy. Thank you for that. And
you're welcome. Grape or strawberry?
I've heard that. I've never done that or seen it done either, but I read that or heard that taking a glucose, it'll read about like 35 to 45 or something there.
Yeah, which again is also all these people have tried to come up with these creative ways to determine, use a glucometer, use a gauze. At the end of the day, they got a brain bleed, they need to get to a hospital, right? So you've determined this, cool. Now they got a brain bleed. What are you going to do about it in the ambulance? Let the hospital know if you are able to determine it. But we've gotten to a point in medicine with anybody that's got type of head injury, they're going to get a CAT scan anyway. So it's just confirming what they're going to find out. So medical care for internal bleeding usually requires surgery or other hospital procedures. Unfortunately, we're not going to be doing that in the back of an ambulance. Keep the patient calm, reassured, and still and quiet as possible. You're going to provide high flow oxygen, maintain body temperature, and splint the injury or extremity if needed. They really like air splints in this lecture. All right. But I guess we're going to get to the review part. All right. What of the following is not a component of the cardiovascular system?
B.
Anybody? I got Tina. Anybody else?
B. Can you hear me? I said B.
B. Sorry, I was
Good job,
muted.
guys.
I don't know if you can.
Components of the capillary system include the heart, blood vessels, and blood vessels and the blood. The lungs are not a component. An important part of the respiratory, and they work together, but not part of that system. Perfusion is most accurately defined as A, the removal of adequate amounts of carbon dioxide during exhalation, the intake of adequate amounts of oxygen during the inhalation phase, circulation of blood within an organ with sufficient amount of oxygen, or the production of carbon dioxide which accumulates at the cellular level. Anybody?
C.
C. I was thinking C.
All right, let's see what we got. C. Everybody feel comfortable with that? Kind of a long question. A man is involved in a motorcycle crash and has multiple abrasions and lacerations. Which of the following injury has the highest treatment priority? A. Widespread abrasions to the back with pinkish ooze. B. A 3-inch laceration to the forehead with dark red blood flowing. C. A laceration to the forearm with obvious debris in the wound. Or D. A 1-inch laceration to the thigh with spurting bright red blood.
That'd be D.
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 Good job, guys. That was an easy one. All right. Which of the following sets of vital signs is least indicative of internal bleeding? We talked about this.
I'm thinking A.
A.
Low heart rate and high blood pressure.
But it's least indicative.
Right, and that's 8 breaths, so that's C. So yeah, A.
All right, guys. Good job. That is a mean question. Least indicative. So,
Would
for me, if
C
I look at
be-
that, I don't know what PowerPoint's deal is.
Would
Sorry,
C be
guys.
the answer if it was indicative of internal bleeding?
It was
the
90. It was the heart rate with the 90s in it. Hold on.
Yeah, that's
I think
C.
it was
Okay,
C.
good.
Yeah. And so if you were to just read that question, 100%, yeah, that's 100% what I would pick without noticing the part where it said the least. So make sure you guys are reading those questions. And again, that's what's going to happen on the National Registry. They love those type of questions. All right. Come on.
Thinking D.
Is that a different one? Okay. Which, when caring for a patient with internal bleeding, the EMT must first.
D.
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 Standard precautions.
Good job. That was another. These are the tricky ones tonight. All right, D. Make sure you got the standard precautions in place.
There was a question at the end of one of these chapters that assumed that the whole crew that showed up was basic EMTs, and the answer was call for ALS. And I had said bring them to a trauma 1 unit, a trauma 1 hospital, and that could have been the right answer, but yeah, that was a trick question for me.
The most right, though.
Yeah,
you have
yeah,
to look for the
exactly.
most right.
Yeah, but
All
it
right,
didn't
guys.
say on there you're with a bunch of basic EMTs. That's the weird, All right.
This one, I don't like this question, but we'll see what it is. The quickest and most effective way to control external bleeding from an extremity is
B.
Pressure banded, direct pressure. Oh, no, it's definitely not.
B.
Tourniquet.
All right. You guys all right with that? I will tell you from a tactical medic side of things, I'll slap a tourniquet on and just go with it. But in the everyday world, you're going to put direct pressure. All right. When applying a tourniquet to an amputated arm, the EMT should.
It's not D.
You're not supposed to put it over the joint.
Not B. B.
I think it's B.
I wonder if this is a typo. So it should say line attorney gets an arm, EMT. Yes, sorry, no, it is right. Avoid over a joint. So you don't want to put it anywhere where something has to move at an angle. So shoulder, an elbow, a knee. You want to go above or below.
Well, it's not that, right? Zach, isn't it? Isn't it because you could apply a ton of pressure and you just wouldn't constrict that vein or that vessel to
Yeah.
stop the flow of
No,
blood.
and that's 100% the reason why. My thing is just don't put it anywhere anything bends. That's just a kind of a placement thing.
Yeah.
But yeah, that's why you just can't
Yep.
get a good pressure on that. And if they move, then it shifts the tourniquet. It's just not the easiest. All right, a 70-year-old man is experiencing a severe nosebleed. You arrive to find him leaning over a basin, which contains an impressive amount of blood. He has a history of coronary artery disease, diabetes, and migraines and headaches. His BP is 180 over 100. His heart rate is 100. Which of the following is most likely contributing to his nosebleed?
A.
A.
Good job. Cool. All right, and I want to kind of touch base on something real quick. So I said earlier that extensive cocaine use can cause nosebleeds. However, in the hospital, sometimes they will use cocaine to stop a nosebleed. So the erosion from snorting stuff can really tear up the lining of the nose. However, cocaine constricts blood vessels. So sometimes they will use cocaine to actually stop a nosebleed. Fun
They
fact.
have cocaine at hospitals.
They have cocaine. They also have beer and liquor for some alcoholic conditions. So the pharmacy is a party shop.
That's so weird.
Yeah, I worked in an ER, and I remember one time going down to the pharmacy at like 2 a.m. I worked overnights, and they had a box of Natty Light, and I was like, "Why?" And so I learned about that. So, when caring for a patient with severe epistaxis or nosebleed, the most effective way to prevent aspiration of blood is to think about this one. Think of your anatomy.
Bravo, boy.
B.
Good job, guys. B.
Yeah,
Want to
you
get
don't
them
want-
upright. You want to get them leaning forward, and you want to get that blood coming out the nose, not down the back of the throat. Controlling internal bleeding requires
B.
Hey, Zach, real quick
E.
question. When
Yes,
they're
sir.
talking about stopping a nosebleed and you're pinching the soft part of the nose, or they had showed the picture how you put a piece of like gauze underneath their lip and you fold it up. What are you actually trying to do there? Are you trying? I mean, if you're pinching the nose, it's still bleeding. It's going somewhere.
Yeah.
Right? So is it just pooling? Like, I mean, what's the science behind that?
So the reason you're pinching or even you're putting something under your lip is you're causing pressure. You're doing direct pressure inside the nose. So this is placing pressure on your capillaries. This is pushing up and pushing the skin up inside the nose as well, putting pressure. Now that blood is still going to run down the back of their throats. When they're talking about leaning someone forward, you're still going to do that. And if you apply pressure, you'll know pretty quickly if it's going to slow down or not. Sometimes, and what they're saying here is these people, even with direct pressure and you apply, it is just a fountain. And if you were to lay them back, they can drown, they can aspirate. And then blood and stomach acid make a really bad concoction of making you want to throw up. So these people also, you don't want them throwing up on top of bleeding down their throat, because then when you throw up, everyone knows you start getting that dry heaves, you start kind of clenching up and you're going to build that pressure in your face, and then it's just going to cause it to bleed more. So it's kind of a horrific cycle.
Yep.
So direct pressure via the outside of the nose is basically what's happening.
Because those are where the veins are that are most probably
Capillaries,
bleeding.
yeah. And what happens is a lot of times these patients, especially younger patients that get constant nosebleeds, what they'll do is they'll actually go in and do something called cauterization, which they go in and actually burn those capillaries and vessels in the nose to keep them from bleeding and kind of kills them off. And that, I believe, is that the last one? Is there any more? Nope. Okay, 10. Controlling internal. Wait, just kidding. That's it, guys. All right. Let me stop this recording. We got one more to go. Get back over to Morgan for this last one.